Moving ahead for the day, may I call on stage Dr. Vinanti Golwilkar, and may I request Dr. Ashwini Sengupta to chair the session, please.
Good afternoon. I think my pleasure to introduce Dr. Vinanti Golwilkar. She has completed her MBBS and MD from BJ Medical College and Sassoon's Hospital, Pune, one of my favorite places to go, and excelled in academics with first rank in MD Pathology, and has an opportunity to work at Tata Memorial Hospital, Mumbai, and is doing many new essays and introducing new tests and technologies since she's joined her father's laboratory since 2014 with her interest in hematopathology. So let's hear Dr. Vinanti Golwilkar.
Thank you, ma'am, for the kind introduction. And at the outset, I would like to thank Team Mindray, particularly Shama, for giving me this opportunity. Beginning my talk with a little information about the organization, AG Diagnostics. We are a state-of-art clinical diagnostics laboratory spread over 16,000 square feet in the heart of the city of Pune. We have 60 plus collection centers across Pune and PCMC region with 7 hospital labs. And our strength is our experienced team of technologists and 15 experienced pathologists and microbiologists. I have captured this data for platelet count over the last 6 months in our laboratory so that you will understand the profile of our patients. If you can see, nearly 88 to 90% of our patients fall into the normal range, and moderate to severe thrombocytopenia or severe thrombocytosis accounts for less than 2% of the cases. And accordingly, we have a stringent protocol for release of automated platelet count at AG Diagnostics. So we review any counts less than 1.5 lakhs or more than 5.5 lakhs of per cubic millimeter of platelets, in which case we review the CBC histogram and correlate with the rest of the CBC parameters, associated tests requested like dengue, NS1 or IgM, rapid malaria and fever profile. We go through the delta check available in our lab through our software. If it is our own follow-up patient, we do trend analysis of the count and go through the previous report. A peripheral blood smear review is done by a pathologist where we correlate the platelet count, look for large platelets, giant platelets, platelet clumps, satellitism, possible pseudo thrombocytopenia, presence of microcytic RBCs or RBC fragments, giving possible interferences and associated findings, reactive lymphocytes, malarial parasite. If it is a new patient or there is a significant change in the delta values in our follow-ups, cases of moderate to marked thrombocytopenia, and cases where we feel there is a need to change the count given by the analyzer, it is rechecked by a second pathologist, and then we release the report. So while putting this up, I came across an article which gives a methodical approach to interpreting the platelet parameters of the complete blood count. And what this article states is interpretation of laboratory results by laboratorians incorporates 2 levels of analysis. One is the validity of the results to answer the question, can these results be reported? And the other is the clinical significance, whether subsequent actions like reflex testing, critical values procedures, or notifications to other departments are warranted. Now, the literature frequently contains algorithms that are focused on the diagnostic aspects of test interpretation, but this article has focused on the validation aspect, which it is calling as heuristic, that is, you learn for yourself. And I had described my heuristic or our heuristic at AG Diagnostics in the previous slide. This article mentions the steps for interpreting platelet portion of the complete blood count, where it takes into account the total platelet count, MPV, PDW, the platelet distribution histogram, IPF, then correlate the numerical parameters with the platelet morphology, and then correlate platelet results with RBC, and WBC parameters and conduct clinical assessment of the patient's values. So now moving on to the new kid on the block, which we have installed in one of our hospital laboratories 6 months back. Nice compact tabletop model. The highlights are the 3D SF cube technology and platelet etch and IPF. It also gives ESR with CBC, but that would not be the focus of my talk. So we ran a sample, 39 years male, who had come for a routine checkup on this BC-700. And so I was looking for a platelet count here, and what have I got? So on this, in the WBC diff mode, which is called CD mode on this platform, we got all these results. So a platelet count, which is the platelet etch, because that's what we have selected for our platelet reporting, of 207,000, a platelet I by impedance of 206,000. We also got PLCC and IPF in the diff channel itself. Going through the principles, it applies sheet flow impedance method for RBCs and platelets, laser scatter, and the SF cube fluorescent cell analysis technology for the WBC differential. This involves 3D analysis using information from forward laser scatter, side laser scatter, and fluorescent signals. Platelets are measured by the sheet flow impedance method, which counts platelets by sorting and detecting the pulses falling in the platelet channel per cell size. However, we all know that impedance method is vulnerable to interferences. We can get a false high value in the presence of microcytic RBCs or RBC fragments. We can get a false low value in the presence of large platelets. Possible solution till now has been optical platelets, but it has to be rerun in the reticulocyte channel involving extra reagent consumption, a rerun and higher cost. So now we have another solution, this platelet etch or platelet count hybrid on the BC-700. Here platelets are counted in the diff channel, which adopts the fluorescent staining technology. RBCs are lyse, so the count of platelets in the relatively large sizes in the diff channel will not be affected by the erythrocytes. Now, by combining the large size platelet count result in the diff channel and the small size platelet count result in the impedance channel, the analyzer arrives at the platelet etch, which is a reportable parameter on this instrument and is said to have the same clinical performance as platelet O. Results have been found to be stable up to 24 hours at room temperature and 48 hours if maintained in appropriate cold chain during transport. So these are the various platelet parameters available on this instrument. Platelet count I've already discussed, mean platelet volume, which is calculated based on the platelet histogram, platelet distribution width derived from the platelet histogram as 10 geometric SD, platelet grid. But what we also have is the platelet large cell ratio, immature platelet fraction, and the platelet count hybrid. So platelet large cell ratio is derived from the platelet histogram. It represents the ratio of the number of platelets with a size over 12 femtoliters to the total platelet number. So the S2 region in this figure. This is taken from the diff channel combined with the small platelets on the impedance channel, and the platelet etch is arrived at. So platelet I, platelet etch, and platelet O, all of them are reportable parameters. Only platelet will be shown in the reportable page. You can look for the other counts in the other parameter page. The CBC mode reports platelet I. CD mode reports platelet etch. CDR, that is the retic channel mode, will report platelet O. So what are the advantages of platelet etch? We can say an optical equivalent of platelets in every CD test. It avoids interferences of fragmented RBCs, microcytic RBCs, or large platelets. There is no need of a red channel or red reagents and no additional reagent consumption in the CD mode. However, it does not solve platelet clumping problem, which is possible only with platelet O. where it can deaggregate the platelet clumps. I'll take you through a few cases. This was a 66 years old male, known case of prostate cancer on chemotherapy. This is the run on our DXH 900, which showed a platelet count of 40,000. There was no review flag by impedance method. We ran it on the BC-700. Again, we got a platelet count, platelet H 40,000, platelet I 41,000, so correlating, and the IPF was 8.5%. Now, it is important to note that the normal range for IPF on this analyzer has been defined up to 10%. So this falls within the normal range. Just showing a snapshot of the delta review we get from AG Diagnostics lab software, and we monitor platelet counts likewise. So this is the same patient, and the platelet count has remained in a similar range on further follow-ups. The next is a case, 39 years of male, dengue NS1 positive on follow-up for platelet count. We saw reactive lymphocytes on peripheral blood smear and large platelets. So this was our DXH run, showed a platelet count of 20,000. However, there was a R review flag, which alerted us to a possible presence of large platelets. On the BC-700, the platelet H was slightly higher, 27,000, platelet I 22,000, and an IPF of 22.9%. This was a 76 years male patient, known case of immune thrombocytopenic purpura. So platelet H and I gave similar values. IPF was high, 21.9%. We got this IPF confirmed on an optical platform, wherein the IPF value came to be 19.8%, so it correlated. So till now, I took you through case of cancer chemotherapy follow-up, which showed a normal IPF. A case of dengue, NS1 positive follow-up platelets showing a high IPF, and ITP showing high IPF. But now I'm going to get an interesting perspective with this particular case, which was admitted in this hospital, where we have this instrument with urosepsis, 72 years male. So the platelet H here was 70, platelet I was lower, 53, showing possible large platelets. IPF was higher normal, 10.6%, MPV also high normal. The patient, being that of sepsis, had marked polymorphonuclear leukocytosis. This was day 1. On day 2, platelets fell a little further, but IPF went up, 15.3%. WBC count came down a little with antibiotic therapy initiation. Day 3, platelet count went a little down further, but IPF went up markedly, 32.9%. WBC total count has come within the normal range. So this is what we have got, the data of the same patient over 3 days. So WBC count has come down with antibiotic therapy initiation. Platelet H has come down slightly. Platelet I parallelly is lower than platelet H. IPF has gone on increasing. Basically, there is so much data. So here I would take this saying, now we are going to get a lot of data in the routine diff channel run, and we could possibly have many associations which we do not know at this point in time, and our eyes don't see what the mind doesn't know. And in this era of predictive healthcare, artificial intelligence, data analytics, I think we have a lot of scope with all this data coming with every analysis. So a lot of studies are now coming with respect to platelets. So till now, we were looking at IPF as a good prognostic marker in thrombocytopenic patients. But IPF and MPV are now considered as adverse cardiovascular risk markers akin to CRP in HSCRP, and studies are going on, and we can have a lot of such data coming up in future. So we have been reporting IPF on this platform over the last 3 months. To summarize, platelet H and IPF on BC-700 has shown good correlation with morphology on peripheral smear and clinical findings. Several new parameters available with every run on the CD module. So it's like a playground for data analytics to give new insights into possible associations and clinical applications. And still there is a lot of scope for learning in near future. I would like to thank my team and thank you all for your patient listening.
Thank you, Dr. Golwilkar. I think that was very elucidative, and thank you for new parameters, that is platelet H and IPF has been there for quite some time now, but yes, more work can be done in other in situations like cardiovascular. So this is open for discussion. Yes, ma'am.
Very good compilation of data, Vinanti.
Thank you.
Very nice to see that. One little query is there. Normally we say that if IPF increases, then within 24 to 48 hours, you would expect an increase in the platelet counts. Now for 3 days, the IPF has been increasing and the platelets have been falling. Any thoughts on that? Have you seen the 5th day report, whether the counts came up or not?
Ma'am, the patient was discharged, so I got only 3 days.
Yeah, because...
But that's what I have mentioned. It's a scope. We have never analyzed it all together in a complete way. So it could bring us new insights, is what I thought.
Yeah, we would.
Ma'am, that was a very interesting question. Actually, we have seen cases where the IPF has gone up and we expected the platelet count to recover within 2 to 3 days or maximally 4. So we went back and we saw the data and we realized in some of the cases, the CBC showed a macrocytic indices. We got the serum B12 and folate done for those patients and it came out to be low. We gave them B12 and the platelets recovered. So when the platelets actually fall, then recovery is tough if you have a deficiency of B12 or folate. So one of the experiences.